An 80-year-old male presents with chronic knee pain and swelling. I am showing you AP and lateral knee radiographs, coronal T1, coronal stir magnetic resonance images, and an axial computed tomography of the distal femur. Please describe the findings.
The radiographs show a near-normal joint, but the lateral view reveals subtle permeative lytic channels in the distal femur. The magnetic resonance images demonstrate extensive, infiltrative marrow replacement throughout the distal femoral metadiaphysis and epiphysis, with minimal soft tissue extension.
What is your primary diagnostic concern?
The striking mismatch between a near-normal radiograph and extensive intramedullary marrow infiltration on magnetic resonance imaging is highly characteristic of primary lymphoma of bone, typically diffuse large B-cell type.
What is the hallmark radiographic and magnetic resonance imaging feature of primary lymphoma of bone that explains this clinical mismatch?
The hallmark is the presence of extensive medullary marrow replacement and soft tissue extension with minimal or absent cortical bone destruction on radiographs, as tumor cells permeate through intact cortical bone via microscopic Haversian channels.
Where does primary lymphoma of bone most commonly occur in the skeleton, and how does this differ from secondary lymphoma?
Primary bone lymphoma classically involves the long tubular bones, with a strong predilection for the knee region, including the distal femur and proximal tibia. Secondary lymphoma typically involves the axial skeleton and flat bones.
What radiographic finding can occasionally be seen in primary lymphoma of bone that helps differentiate it from metastatic disease?
The presence of a bony sequestrum, representing a piece of dead bone isolated within the lytic lesion, is a useful finding that can help differentiate primary lymphoma from metastases.
What is the differential diagnosis for an aggressive-appearing permeative lytic lesion around the knee?
The differential includes osteomyelitis, osteolytic metastasis, Ewing sarcoma, and osteosarcoma. Ewing sarcoma presents similarly, but typically affects a much younger pediatric age group.
Why is making an accurate diagnosis of primary lymphoma of bone particularly critical compared to its imaging mimics?
It is critical because primary bone lymphoma has a significantly better prognosis and survival rate, often over 80% at 5 years, compared to osteolytic metastatic disease or primary osteosarcoma.
Finally, what are your clinical management recommendations?
I recommend image-guided biopsy of the marrow abnormality for histopathological subtyping, staging with whole-body PET computed tomography, and referral to oncology for systemic chemotherapy, which is the cornerstone of treatment.